Um, well, first of all, thank you all for coming to this important event to celebrate, perhaps it's not the right word, a special day, the Suicide Prevention Day, which is sort of, something that is celebrated all over the world. In fact, before I came in here, can you hear well is it working, the microphone? No? I can shout, or this one may be better. Yeah?
I think so.
Yeah? Okay. So, as I said, this is a special occasion in celebration, if we can call it that way, of the Suicide Prevention Day, which is something that all over the world is somehow highlighted. In fact, before I came here, I had a quick look at the websites, and there were lots of different things all over the world happening today. We are lucky to have a couple of very distinguished and experienced speakers in the subject. But before I introduce the speakers, let me just sort of remind you, perhaps it may be unnecessary, but remind you that suicide is a major problem all throughout the world. It is estimated about 800 to 1 million people kill themselves every year, and as you can imagine, the majority of these people come from low and middle income countries, something which isn't always highlighted as such. So it's not just a problem of rich and westernized countries. It happens everywhere. And perhaps the other thing that really, to me, is a major issue to highlight, it is that suicide is the second leading cause of death, mortality, among young people within the ages of 15 to 19. So it's a tremendous tragedy, not just simply for society because of the loss of young people, but it's also a tragedy for the families and all those that suffer with the loss of someone they love. So suicide is a major thing. What we are not at all clear is what we can do about it, and ideally, what can be done to prevent such a tragedy. And it is for this reason that we have invited a couple of people who have worked on the prevention of suicide in 2 different parts of the world, which is one of the wonderful things to have them here. One of them is from South Africa, so can give us that perspective. And the other person can give us a perspective of Asia, an Asian setting, in this case Sri Lanka. So it's wonderful to have that opportunity and contrast that with the experience that many of you have had from other parts of the world. So perhaps I should introduce. Well, before that, I think I have to give you some of the usual practical information. Following the speaker presentation, we will have about 10 minutes for questions, and those who are attending through the webinar should email the question to us to MHIN address. So let me first of all introduce our first speaker, Dr. Erminia Colucci. She is a lecturer at Queen Mary University here in London, right? And she's also leading a master program in transcultural mental health care. Before she came to London, she was just telling me before we started, she spent quite a few years in Australia working in global mental health, of course, at the University of Melbourne. Erminia is a very interesting speaker also because she brings a different perspective different from what I'm used to see. She's an anthropologist. I was just trying to get, because she's done something which is called visual anthropology. just before we started, I was trying to get her to give me a definition of such a thing, because I thought it was really fascinating. But she said, no, this is more complicated than for a conversation of 5 minutes. One other thing to say about Armenia is that, and perhaps, congratulations. I understand that you've recently received an award from the International Association for Suicide Prevention in acknowledging your wonderful work in Sri Lanka. So let's get on with your presentation in Armenia, and then I will introduce our next speakers.
Thank you so much to everybody for being here, although there is a beautiful sunshine outside at our event in this city. And thank you for contributing to the World Suicide Prevention Day. Thank you for inviting me to be part of this one, both of them. She warned me, this table moves up and down, so if I start screaming, you know why. So I'm going to be talking, actually, Ricardo just gave half of my presentation, so I'm going to be skipping some slides. I'm going to be talking about prevention of suicide in Sri Lanka, but giving you also a bit of a background around the community-based suicide prevention, which is my kind of approach about prevention of suicide. And I'll be referring to a very important document, which you can see here. Here we go. Preventing Suicide, a global imperative, which is a document which was a report prepared by WHO last year, which is a very important report in this area. So if you are interested in this topic, please do have a read this document. So some of the data I'm going to be giving now are from this report. This is a map showing the age standardized suicide rates. And as you can see, can't go in depth, but there are a lot of geographical variations about suicide rates. And as Ricardo just mentioned, the rate of suicide actually are higher in high-income country compared to low-income country, although there is not much of variety, 12.7 versus 11.2 per 100,000, and we know that the statistics in low-income countries are kind of not as reliable, so probably is an underestimate. However, even based on these rates, we know that because the larger population in the world does live in low and middle income country, it means that around 70.5% of all suicide in the world actually occur in low and middle income countries. And only looking in the Southeast Asia region, which is where I've done most of my work, 39% of all suicide happen in that area. There are variations in the rate of suicide also based on age and gender. So as Ricardo mentioned, in the young adult between 15 and 29 years of age, suicide accounts for 8.5% of all deaths. It is ranked as the second leading cause of death after traffic accident, although we know that some of these traffic accidents actually are suicide. In low-middle-income countries of the Southeast Asia region, suicide is the leading cause of death among young people. And there are also variations about women and male. Usually, the more male kill themselves compared to female. The ratio is usually 3-1 or 4-1. But in low-middle income country, there is almost the same number of people, male and females. It's around 1.5-1. So globally, 50% of all violent deaths actually are in men, and 71% in women are about suicide. Now, suicide, there are different reasons for suicide. Often people ask me why people kill themselves, and there isn't an answer, as there is not one answer about what's visual anthropology. But there is many reasons. There are different pathways to suicide. This means that the way to prevent suicide also must be multi-sectorial and multi-component. And there is some evidence suggesting that multi-component programs are associated with some successful reduction in suicide rates. WHO has done this kind of complex but interesting figure, basically putting in relation the kind of risk factor for suicide at different level with different kind of strategies to prevent suicide. What I'm going to be talking about in the rest of my presentation is this area of prevention of suicide, which is the gatekeeper training. Sorry, I moved too much. Maybe I should try to stay a bit more still. So what is gatekeeper training? Basically, the gatekeeper training is based on the understanding that individuals at risk of suicide usually don't seek for help directly or explicitly. However, they might exhibit risk factor. They might show some warning signs that actually can identify them as being at risk for suicide. So a gatekeeper is anyone in a position to identify whether somebody might be contemplating suicide. And gatekeeper programs aim to develop participants' knowledge, attitudes, and skill to identify people at risk of suicide, determine how much is the level of risk, and referring them for treatment. That's when treatment is available indeed, and when people actually are willing to seek this kind of help. So within this kind of area of gatekeepers training sits the kind of suicide first aid guidelines, which I'll be talking about in the rest of my presentation, which is basically a tool we've been developing in Australia at the University of Melbourne together with the mental health first aid. And the kind of thinking around and awareness of suicide first aid guidelines are that members of the community who are close to a person at risk of suicide, like a friend, a family member, a co-worker, a classmate, are the people more likely to kind of identify some of the warning signs for suicide. So they're the people more likely to actually perceive that maybe something might not be quite right. However, these people usually don't have knowledge about how to identify a behavior or a lack of behavior as a warning sign for suicide and how to respond to these kind of behaviors. So our thinking is, if members of the public were provided with simple and practical guidelines, very practical, about how they should provide first aid to a person who is suicidal, they might actually be able to help this person to seek help or decide against suicide. Then this guideline can be applied in gatekeepers training as the one I just was talking about. So far we have developed 4 guidelines for Asian countries in Japan, Philippines, India, and Sri Lanka, and also for people from immigrant and refugee background. And in the final part of my presentation, I'm going to be talking about the last newborn guidelines, which you are the first people actually to see. They're kind of not completely finished, but kind of. So these are the one for Sri Lanka, and I can pass them around if you want to have a look at them. So they're here. And basically they we are just writing a paper about them, so they're the new addition to the collection. So these guidelines, all 5 of them, are based on the same kind of methodology. So there was at the beginning a systematic literature review to kind of try to see the evidence about prevention of suicide, and also based on other guides and other relevant websites. Based on this literature review, then we developed a questionnaire with basically the warning sign for suicide and the first aid action to prevent suicide. And the third phase of the process was having an expert consensus study, basically a Delphi method project, to have consensus from experts in these different countries about what should become part of these guidelines. So the guidelines are very much evidence-based and to a research process. So this is kind of the kind of scheme of the different stages. Don't get scared, I'm not going to go through them. But basically, there are 3 different rounds of the Delphi studies. So it's a kind of a back and forth between a researcher, which was mainly me in this case, and the experts to try to reach an agreement. And our criteria for the agreement was quite high. It was 80%. So only the items where 80% of the experts agreed that it should be part of these guidelines, they became part of it. If you want to read about the process, there are papers about it, and you can see the methodology. So the outcomes of this process was basically developing, having a set of agreed upon statements about how to provide help to somebody at risk of suicide and what are the warning signs relevant for these particular countries. These guidelines have been published as articles in free open access journals, and they are freely available through website. So we really want them to be part of the public and be used by whoever really wants to make use of them. So these are the kind of instruments we developed so far. So there is this is one for Philippines. We also did a training in the Philippines. So we also have a manual for using these guidelines. There is guidelines for India, Japan. There are some infographic. The one for Philippines is there. This one is the infographic for immigrant refugees background, and the Sri Lankan one. So now the Sri Lanka. Just a little bit of background about Sri Lanka suicide. Sri Lanka, as many of you might know, it has one of the highest rate of suicide in the world. It's around 25 per 100,000. This was a 10 years ago statistic. However, this is quite high, but actually it is lower compared to what it was not long ago. The rate of suicide in Sri Lanka in 1995 were 47 for 100,000. And the reason why there has been such a quite a big reduction is because Sri Lanka is one of the few low-middle income countries that has formulated a specific national suicide prevention plan and taken action to reduce suicide, particularly through pesticide control, which has been the main strategies to prevent suicide in Sri Lanka. So the process for the Sri Lanka guidelines was the same as what just mentioned. So we started with a questionnaire which had 473 items, and by the end of the third round of the process, we had 3 or 5 items, which then basically became part of these guidelines. So they are going around, but just I'm going to click here and magically they're going to appear. So just taking you quickly through them. But they will be available online if you want to see them. So basically they have some facts about suicide warning signs, so how to tell if somebody is feeling suicidal, what are some of the signs for suicide relevant to Sri Lanka, how to approach the person, number of boxes about specific kind of tips, and like listening tips and the communication difficulties, to do and not to do, how to tell it, how urgent the situation is. I don't know if you can see much. Maybe I should make it a bit bigger. Can you see better? More? Yeah? How to keep the person safe. So everything written here, which was written in a very narrative and lay people language, basically came out of a research process. So every single thing written here was originally a statement in a questionnaire. It's a safety plan, and how to get the professional help if there is available. Yeah, so if you want to have a look at them then later, they're gonna go around. So now what's next? So we are open to translating the guidelines in Sinhala and Tamil, which are the two other in English language spoken in Sri Lanka. We also open, as for all our guidelines, to develop some training package, basically to train the trainer kind of a package for people then to go in the community and train other members of the community. And this kind of training, as for the Philippines, where we had a manual. This project here was supported by WHO and CBM. So we had a training manual, and then we also basically worked with a theater company based in Philippines to develop some kind of plays based on the guidelines to help people who were trained to recognize some of the warning signs for suicide, but also try to put in action some of the things they actually were learning through the guidelines. Because it's not easy, like reading something obviously sounds always much easier than then putting in practice. And sometimes it's also about acknowledging the difficulties, for example, of asking to somebody, are you actually considering killing yourself? The question which could save life can be actually so difficult to ask. So if we have time, Vanita, we have time? Yeah? I'm going to just show you a very little clip from a video made of one of the training in the Philippines. And whatever is there came out of the guidelines. This is if this works. Something is happening. Yep, it was working before, so we are hopeful. Optimism. Maybe if I press it. Yeah.
Susi! Ang hali na! Ano ba yan? Ano yung itsura mo? Ba't ganyan na itsura? Magpalit ka nga ng damit. Papasok ka sa eskwelahan. Ganyan ang itsura mo. Magpalit ka ng damit doon. Ano ba naman tong batang ito? Papasok ka sa eskwelahan. Baka mamaya hindi papasukin ng guard. Ano nga itsura mo? Wala na akong damit eh. Maganap ka dyan! Kakalaba ko lang! Wala na nga! Meron dyan! Susi, tanghali na! Asan ka ba? Pakapalit ng damit! Hindi ka nga dito.
Wala na akong damit.
Ano to? Bakit hindi mo to binibigay sa akin? Kuhanan pala ng cards mo mamaya. Susi, last week pa to binigay. Bakit hindi mo man lang ako sinabihan? Hindi mo inabot sa akin to?
Sinabi ko yan sa'yo, hindi ka nakikinig.
Anong hindi ako nakikinig? Eh, nasa bag mo nga yan, hindi ko...
O, ayan
Paano
ako.
ko pupunta sa eskwela? Nidadalhin ko si Junjun. Nilalagnak ka naman yung kapatid mo. Ito naman batang to, parang walang pakialam mo. Ano, mas ka uwi mamaya?
Eh, di gabi na.
Paano ko makukuha yung card mo? Teka nga muna. Last quarter ba, sinong kumuha ng card mo? At teka, wala akong nakita, wala akong napirmahan.
Pinakita ko yun sa'yo.
Anong pinakita? Hindi ko nga maaalala eh.
Eh, paano kasi ang dami ginagawa? Hindi ka nakikinig sa akin.
Hindi talaga akong ginagawa. Yung kapatid mo, yan ang kinabibisihan ko. Yung paghahanda ng mga almusal nyo, yung paghahanda ng mga gamit nyo. Diyos ko naman, Susie, hindi ka naman dating ganyan na. Alam mo na, mahirap alagaan si Junjun. Bata pa yun. Bata pa yung kapatid mo.
Eh, hindi ka kasi nakikinig sa akin eh. Pag tinatawag kita, hindi mo ako pinapansin.
Eh, kasi nga, hindi ba pwedeng tulungan mo na lang ako sa kapatid mo? Teka muna, paano ko malalaman ano ba nangyayari sa grades mo? Aba, dati lagi akong pinapatawag ng mga teacher mo kasi bibigyan ka nila ng award, bibigyan ka ng certificate. Ngayon, parang wala akong naririnig. Ano na ba nangyayari sa'yo at ba't hindi mo pinapakita yung mga cards mo?
Ewan ko sa'yo.
Ang batang to. Hoy, Susie! Bumalik ka nga dito! Malilate ka na! Ganyan ka lagi.
This is just a little excerpt from one of the videos. We did 4 different scenes, and the idea was about having people who were trained about the guidelines to then try to talk to Susie, try to imagine they actually were the mother and what they might be saying, or a friend, what actually they could be saying to Susie, or in this case, had shown some of the warning sign for suicide for the Philippines. There's a little example. We've done similar videos also for people from migrants and refugee background, and hopefully we continue to develop training tools like this. So concluding in perfect time, basically members of the public and people, the minimally trained health workers in Sri Lanka, but also in other low middle income countries, really can play an important role in prevention of suicide. And I strongly believe in this. Through my work in Asian countries, but as in other low middle countries, I really believe it's very important. It's a very big part of prevention of suicide. And gatekeepers training are part of these community-based suicide prevention strategies. However, all gatekeeper trainings must be culturally adapted. They can't just be taken from one country and transferred to another country or very minimally modified. We tried, and I'm not saying we've done our best, and that's the best way to do it, but we at least tried to develop an instrument which was done by people with local knowledge, totally done by people with local knowledge, because they have to be culturally and locally relevant. Otherwise, they will not be as successful. And the WHO report indicated that adapted programs have shown promising results when tailored to specific populations. So on that note, I'm going to close. There are some references if you want to read more about the guidelines, the WHO report. In these websites, you can actually find all the guidelines and download them. The Sri Lanka one is not there yet, but it will be soon. And please, if you can, make use of them. And that's my email. Thank you so much.
Thank you very much, Armenia. I'm sure there will be lots of questions about your experience in Sri Lanka. Let's move on to our next speaker, who is Dr. Jason Bunges. I'm sure that I pronounced his name wrongly. Jason is a psychologist, comes from the University of Stellenbosch in South Africa. He is also a course director of the master's degree in clinical psychology and community counseling at Stellenbosch University. He's also he's so many things for such a young man. He's also the representative, the South African national representative for the International Association of Suicide Prevention, and currently holds a research award from the South African Medical Research Council to work on suicide and deliberate self-harm. So, without further ado, Jason, the platform is yours.
Thank you. Thanks for the opportunity to talk a little bit about the work we're doing in South Africa around suicide prevention. As you can see, the subtitle for this presentation is Challenges and Lost Opportunities, which is a bit of a bleak subtitle. But given that our focus is suicide and suicide prevention, I'm hoping to be able to get away with the negative focus. There are three things that I'd like to try and do in the next 20 minutes. The first of those is to give a brief overview of suicidal behavior in South Africa, to kind of as the backdrop for the research that we've been doing, and to set the scene for the second two parts of the presentation. In the second part of the presentation, I'd like to look at some of the obstacles to suicide prevention in South Africa, so that we can think a little bit about those in terms of the way forward and what might be required in order to become more effective at suicide prevention. We don't have a national suicide prevention strategy for the country, and you'll begin to understand why as we go through the information that's presented there. And then in the third and last part of the presentation, I'd like to talk about lost opportunities and focus in on a very particular research project that we currently have just finished off doing with colleagues at the University of Cape Town, to look at the organisation of care in a public hospital. So it's looking at a very kind of a microscopic view of the organisation of care for suicide attempters, and to try and highlight what that illustrates about lost opportunities for suicide prevention. Fatal suicidal behavior in South Africa, it's remarkably difficult to get reliable statistics. There is a mortuary surveillance system in place which has some coverage of national mortuaries, and from those we're able to get some kinds of estimates of what the prevalence of suicidal behavior is. From these, the kind of conservative estimates based on these figures suggest that suicide accounts for just shy of 10% of all unnatural deaths, that we have about 18 completed suicides a day, and that the prevalence of suicidal behavior is just shy of 14 per 100,000, which is a little bit higher than the world average. But as I say, these are conservative estimates, and that if we had broader coverage of the country, we might find that those figures might not be as accurate as we'd like to think they are. In terms of non-fatal suicidal behavior, it's estimated that for every completed suicide in the country, there are about 20 non-fatal attempts. We have no idea of the impact of completed suicides. We have no idea of those who are bereaved by suicide, what the impact is on them, and how many people's lives are touched by the suicide of someone that they know. There is some data indicating lifetime prevalence and one-year prevalence of non-fatal suicidal behavior in nationally representative community samples. So we get a sense of how frequent suicidal thoughts are, suicide attempts, suicide plans are within the country. But the data really lacks context-specific and useful subtleties to make it easily applicable or transferable into suicide prevention programs. As we've heard, the World Health Organization estimates that about 75% of suicides occur in low and middle income countries. But unfortunately, the majority of research comes from high income Western developed countries. And as we've just heard in the previous presentation, it's sometimes really difficult to take research that's done in very particular contexts and just simply transfer it into another context. What we seem to be lacking in our setting is context specific data about the situations in which the situated meanings of suicidal behavior, the cultural meanings of those behaviors, but also the specific contexts in which those behaviors occur, which makes it hard to plan suicide prevention strategies. This lack of knowledge, if we do look at the knowledge that we have, there are a handful of studies that have looked at, for example, fatal suicidal behavior. But these studies have tended to be remarkably unsophisticated. They've tended to be retrospective reviews of mortuary data. They've reported on convenient variables like age, gender, time of death, method of death, the kinds of variables that you would routinely find in mortuary records. They've reported them using descriptive statistics, and those studies have been atheoretical. They've been purely descriptive of what is found. As a result of these studies, we've got some idea of the prevalence of suicide. We know, for example, that suicide is 80% of completed suicides are male, so we know that being male would be a risk factor. We know that a majority of suicides occur between individuals between 15 and 29 years of age. but that may be a reflection of the population pyramid in the country, because about half of the country's population is in that age group anyway. So it's not really meaningful to know that in raw numbers that most suicides are in that particular age group. We know that being unemployed is a risk factor. It seems that from some studies that about 40% of individuals who complete suicide are unemployed in a country where official rates of unemployment are about 25%. We also know that there's a huge geographic variation in rates of completed suicide, that in poor rural areas of the country, suicide rates are about 2.5 times higher than they are in the city centres and in urban areas of the country. But what we don't know is much more subtle information about individual factors. For example, studies in developed countries have suggested that psychiatric illness is associated with suicidal behavior, although in other developed countries it seems that the role of psychiatric illness is not as predominant as it might be in the developed country. But we have no information, for example, about how suicide completers' history of contact with the healthcare system. We have no idea of their experience of care. We have no idea of personality factors of individuals who complete suicide. We have even less information about how some of the endemic problems, socio-cultural problems within the country might mediate suicidal behavior. Things like high rates of unemployment and poverty, things like high rates of trauma and violence, how things like that might play a role in suicidal behavior. I guess the challenge for us posed by this obstacle is a need for a much more rigorous and focused research agenda. That there is a dire need, if we want to move towards a national suicide prevention strategy, that there is a need for more qualitative work like psychological autopsy studies, although not limited to psychological autopsy studies, that look at some of the more contextual factors and the socioeconomic context in which suicidal behavior occurs in South Africa. In terms of epidemiological data, we need much more sophisticated studies that are grounded in some kind of theoretical understanding. For example, to think about unemployment and just simply be able to say that 40% of people who are unemployed, among suicide completers, 40% of them are unemployed, tells us nothing about how being a young man in a community where the majority of people are unemployed, how that might mediate suicidal behavior. So we need to think more critically and carefully about the epidemiological data we collect, and collect it much more deliberately to be able to answer questions about the why behind some of the suicidal behavior. I want to turn now to look at lost opportunities for suicide prevention, and this is the work that I alluded to that we're busy with colleagues in the Department of Psychiatry at the University of Cape Town. So I want to say up front, this is the project I'm about to describe to you now. It's not a single person project. There are a lot of us involved, and it was funded by the National Research Foundation, University of Stellenbosch, and the Medical Research Council. It's a bit embarrassing given that I'm a psychologist, but the study I'm going to describe to you now is much more anthropological than psychological, and that's difficult given that our previous speaker is an anthropologist, so forgive me if I blunder my way through anthropology. But I think that anthropology holds a lot of value and promise in understanding not only healthcare systems but suicide prevention. So we were interested here, the background to the study is that we know that individuals who engage in self-harm are much more likely to re-engage in self-harm, that there's a high risk of repetition, but that individuals who self-harm are also 20 to 30 times more likely to complete suicide. We know that a lot of people who self-harm don't land up in the hospital system, they don't make contact with the healthcare system, but those who do make contact with the healthcare system, they're a very clearly defined group of individuals, and that contact between them and the healthcare system is an opportunity for an intervention, the opportunity to prevent repetition of both fatal and non-fatal suicidal behavior. So it was in this context that we were interested in how hospitals in South Africa respond to suicide attempters, how care is organized within those hospitals, what the attitudes of healthcare workers are towards these individuals, and what possibilities there might be for hospital-based interventions to work with this population. So that was the context. The method we used was very anthropological. It was a critical ethnography approach that we used. We were in the hospital for a period of about 8 months. It was just over 8 months, actually. And during that time, we did a number of things. We attended ward rounds within the hospital, watching how doctors and nurses spoke about suicide attempters, what kinds of procedures were in place. We followed patients through the hospital who had self-harmed to see which wards they landed up in, what kinds of interventions were offered, what care was offered to them. We kept a register of all self-harm patients that were admitted to the hospital during that time, or who were treated in the emergency room and then discharged. And we collected data about who those patients were. We did interviews with 37 medical staff. These included nurses, medical officers, registrars, social workers, about their understanding of the procedures in place and their ideas about suicide prevention, hospital-based suicide prevention, but as well as their attitudes towards suicide and self-harm. We also interviewed just over 80 patients who'd been admitted to hospital. These were all patients who'd had medically serious incidents of self-harm. In other words, their self-harm was so serious that they had to be admitted for medical care as a result of their injuries. So there was often a very high intentionality or lethal means that they used. And among other things, we asked them about their experience of care and what they thought they needed in order to prevent repetition of self-harm. I'm going to focus on maybe I should say something about the setting of this particular hospital. I am going to show some images. The images are not images of the particular hospital where the study was done. These are generic images which occurred which were in newspaper reports, but they do give a sense of what the environment is like and what the inside of public hospitals within South Africa look like. The hospital that we chose to do this study in is a fairly large hospital. We're talking about 43,000 admissions a year, about 900 beds in this hospital, 500 doctors, 1,400 nurses. So by South African standards, this is a large hospital. But it's an academic hospital, it's a teaching hospital, and so it's part of the environment where medical professionals in the country are socialized into care and socialized into their profession, which makes it a particularly interesting site to do a study like this. But the point is also that this is a very well-resourced hospital, so that there are probably other hospitals where the organization of care might not even be as sophisticated or as developed as this. The 9 findings that I'd like to focus on, and I've put up extracts from some of the interviews so that you can get a flavor of what the patients were saying. And I focused here on patients' words, although I'll talk a lot about our observations and what the medical staff said to us in their interviews. The first thing that stands out from the data is the description of quite a positive experience of care. The patients felt that the medical care they were getting was really good and they felt taken care of and that the medical staff had done a really good job. But the practice in this particular hospital, and maybe it's the same in this country, is that suicide attempters who are admitted to a hospital, once they're medically stable, are admitted to emergency psychiatric wards, where they're observed and assessed, and then from there they're either discharged or they are transferred to a therapeutic ward in a therapeutic environment. And the kinds of patients that go into emergency psychiatric units in South African hospitals are psychotic individuals with high levels of behavioral disturbances. So the environment is quite a chaotic, crazy, loud environment. And so the patients we spoke to spoke about how terrifying it was to be admitted to an emergency psychiatric unit, to be surrounded by individuals who they perceived as quite mad, in the sense that they were often psychotic. And I'll come back to talking about that psychosis in a moment. But the effect of being surrounded by behaviorally disturbed and psychotic individuals was that there was a sense of alienation, that they didn't experience themselves as psychiatric patients, although they were aware that they were being admitted to an emergency psychiatric ward and they were being treated like psychiatric patients. Very often they explained their own behavior to us in terms of, I have these interpersonal difficulties, I'm having difficulties with finding a job, I'm having difficulties with financial concerns, with a number of very real situational stresses. And their perception was that they needed help with those problems, but that they didn't see themselves necessarily as psychiatrically ill. So the experience of being treated like a psychiatric patient was alienating and potentially pathologizing. They were worried about the implications, not necessarily the implications for medical staff, but how their friends and family might react to them being admitted as a psychiatric patient. Alongside that, they they spoke about the discontinuity of care. This is a training institution, and with the result that they assessed by a different doctor every day, a registrar one day, a medical officer, a medical student the next day. And so the experience of care was that it was very disjointed, that there was not any kind of therapeutic relationship that was established between them and the treating physician. They had no sense of shared responsibility for their care. This was in contrast to a huge amount of conversations we observed among medical staff about patients. There was a lot of thought given to the needs of patients, to the assessment of patients, but that those conversations were happening between professionals and not being communicated back to the patient. The medical staff, for example, in this setting said, we don't have patients of our own in this setting, or we manage beds, not patients in this particular setting. So lack of a therapeutic alliance was something that stood out. The patients also described the indignity and the dehumanization that occurred. Because this is an emergency psychiatric unit, it is really functionally furnished. There's nothing comfortable about it. It's not intended to be a therapeutic environment, and that's very much reflected in how the patients experience it. It's a locked ward. Your personal possessions are taken from you when you're admitted. There's security guards in attendance to control the patient's movement, and they experience that as dehumanizing. They often used words like, we're treated like cattle, or we're treated like animals, to communicate their experience of being in this environment. Closely allied to that was this experience of a loss of agency, the feeling that they had no control over themselves or their movement. And this was interesting given that many of the patients spoke to us about how their suicidal behavior, their deliberate self-harm, had been precipitated by feeling out of control of their lives, feeling that the problems they faced were so large and that they didn't have control. And in some ways their self-harm was almost a way of regaining control or asserting control. And then to be in an environment where their loss of agency is amplified was quite disturbing for them. Related to that, patients said to us that they felt that there was a limit to what could be done to help them in this environment, that the problems that they needed help with were in a sense beyond the bounds of medicine, that they needed assistance with interpersonal difficulties, they needed assistance with situational factors, and that this biomedical orientation of care within the psychiatric unit there were limits to how helpful that was going to be to them. Yeah. Following on from that is this mismatch between what the patients experienced as their needs versus the care that was being offered. This extract here is from a young lady who was grieving after the death of her mother, and she'd been left to look after her young son and her older sister. And her experience was that she needed space to grieve, space to process her feelings. And there was a fantasy in her mind that that's what she was going to get. That was the kind of care she was going to receive in this environment. But in reality, it was not what she experienced. She experienced busy doctors, busy nurses, and no space to talk and process her feelings. With the result that she goes on to say that she starts to distort the way she feels and disguise the way she feels so that she can hasten her discharge. Because the moment she says to the doctors, I no longer feel suicidal, she knows she's going to be discharged, even though the feelings that have precipitated her behavior remain unresolved. As a result, the patients describe their admission as quite counter-therapeutic, that although they say they had good medical care, they describe a mismatch between their immediate needs, their acute needs, and the service that's being provided. If we think about the factors that are highlighted in those findings and why this presents a lost opportunity, I think the first thing that stands out from these findings is the assumption that patients who attempt suicide are mentally ill patients who require psychiatric assessment, and whether that's always true, and whether admissions to emergency psychiatric units are always indicated or necessarily therapeutic for individuals, particularly in this setting. The other thing that it highlights is the lack of community-based psychosocial care. The fact that so many of these individuals had what we might call psychosocial difficulties that then present as a medical problem and create and make use of medical services within general hospitals. And often this is the only way for these individuals to receive care because of the lack of psychosocial support at a community level. It also highlights the reality of the lack of beds and therapeutic wards, because in an ideal system, patients who were admitted to an emergency psychiatric unit, their stay there would be very, very brief. It would be for the period of an assessment, and then, if necessary, transferred to a therapeutic unit or to an outpatient service. But because there are not always beds available, there are very often not beds available in therapeutic wards. There are long waiting periods in emergency psychiatric units. So some of the patients that we tracked would have been in those emergency psychiatric units for 2 or 3 weeks at a time without any psychological intervention, waiting for transfer or waiting for discharge. Under those kinds of circumstances, many patients opt to be discharged while they're waiting for beds in therapeutic wards. But what it also highlights is the lack of psychological input in emergency psychiatric units in South African hospitals and the implications of that for suicide prevention. The last thing I want to talk about is 3 macro level issues which are also highlighted, I think, in these particular findings. The first of these is that although in official policy there is lots of talk about integrated primary healthcare in South Africa, the reality is that primary healthcare is still predominantly biomedical in orientation. There isn't the kind of integrated person-centered care given to individuals at a primary healthcare level in the country. And I think that's clearly illustrated in these findings, the difficulties of not having made that transition and the implications of that for suicide prevention. The other thing that's highlighted in this is the dramatic increase in the last few years of substance-induced psychosis in South Africa, particularly as a result of methamphetamine use. What this has done is it's increased the prevalence of substance-induced psychosis and put increasing strain on emergency psychiatric units. So emergency psychiatric units now are dominated by a large number of individuals with substance-induced psychosis who take a lot of energy, nursing energy, the energy of the psychiatric staff, which leaves then less space for other kinds of psychiatric emergencies like attempted suicide. The Mental Health Care Act is also part of the landscape of the particular organization of care here. The Mental Health Care Act in our country, and it may be similar here, it may not, there's a large bureaucratic requirement out of that. As a result, the medical staff spend a lot of time in emergency psychiatric units filling in forms, documenting things, so much so that one registrar recounted the story of saying to a patient, "Do you know what my job is here?" And the patient saying, "Yes, you're the secretary, you're the one who keeps track of all the papers." As their experience of what psychiatrists in these environments do attend to the bureaucratic needs of the Mental Health Care Act. But in South Africa, the Mental Health Care Act requires a 72-hour assessment period before patients can be transferred to therapeutic wards. Prior to this particular version of the Mental Health Care Act, patients would have been observed for 24 to 48 hours before they could be transferred. Now there are much longer waiting periods in psychiatric wards, together with the lack of beds in therapeutic wards, which means that emergency psychiatric units become holding environments for these patients with no additional increase in psychological staff, so that there's no psychological input, and that has an implication for suicide prevention, particularly with suicide attempters. These are the references for the images that I use. I stress that they were not images taken in the hospital where the study was done, but they do provide some indication of what the inside of that hospital looks like. Thank you very much.
Well, first of all, thank you so much to both speakers for, I think to me the most important thing is for sharing with us and all those who are watching this webinar your experiences, really. And I know there are a lot of people in here from other parts of the world, including myself, that found some of the things that you were showing us something that I've seen so many times. And particularly, I was really interested to hear about the importance of the context, which was highlighted in both presentations. But it is not for me to speak in here, it is for the audience to be able to ask you some questions. Before if anyone has got any question, please, raise your hand and somebody will come with a microphone. Before I do that, there's something that I neglected on my presentation. This is a seminar organized jointly with the London School of Economics the group of health, and so it's a wonderful opportunity to begin collaborating, or perhaps in some cases that there's been an ongoing collaboration, and it is an issue that really has an economic impact that must not be neglected. So, anybody has got questions? Chamaila? Yeah, if you don't mind to come to you can sit on the table. You'll be more comfortable there. I'll join you. Okay. Is it working? Is the other one working? We have the usual technological hiccup.
Yeah. Go.
It was directed at you, so I don't know your name.
Erminia, don't worry.
You said that Sri Lanka had a national suicide prevention strategy.
Yeah.
I was wondering, on a national level, what they've been doing to address the suicide rate and how your project fits in there.
Yeah. Thank you. So, this working? Yeah. No. Well, must be something to press. Yeah.
Over here.
Is it? Yeah, I can see some numbers. Okay.
Oh,
Yeah.
Is it?
Yeah. I think it's okay. Yeah. So but I was mentioning the main up to now the main action based on the national plan which has been taken in Sri Lanka is been about control of pesticide, which it was the main method of suicide in Sri Lanka. A lot of suicide, not only in Sri Lanka, it's similar also in India and other more kind of rural society. A lot of suicide actually are through pesticide use. So there has been a lot of policies to reduce the possible dangers of the pesticide, so they are less lethal, let's say, and also some kind of way to make a more controlled control of pesticide in terms of farmers have to have some kind of cages where these pesticides are kept. They cannot buy more than a certain proportion of a pesticide. So that's been the way in which the national plan has really been kind of acted so far. But so this, which has been working very well in terms that the rate of suicide went from 47 before the national suicide prevention plan to 25 on 100,000. So which is a big change, but 25 is actually a high rate of suicide still. So clearly that's working, but it is not sufficient. And that's the issue around the prevention of suicide. It can never be resulting mainly in investing in one kind of strategy because there are other reasons, other pathways to suicide. And so this kind of, the guidelines I was mentioning are part of this more gatekeepers training. And also it's about making people, I guess, in the community and all of us to feel we also are responsible in our own way to prevent suicide. Because that's, I think, is a big part of prevention of suicide, is about what it's about. And it's also a society level. And there is many things that all of us can actually do to prevent suicide, and not only controlling the pesticides. So yeah, but that's what has been done so far, mainly. Yeah, Peter.
Okay, thank you for your talks, which I really enjoyed. I want to ask about suicide, obviously. I'm a working clinician. I deal with people who are suicidal most days of the week. Often I will see people and I will think, I know you are going to commit suicide. I'll tell them. And I will say, but I don't know when. And I really can't stop you committing suicide unless I lock you up. I just don't know the answer to this. They don't know the answer either. But if I look at the Preventing Suicide report, it's clear that what they say is the aim is really to abolish suicide. And I always struggle to think of, I think suicide in a sense can be part of the nature of man and woman, that there is something, there. I wonder what your perspective is on that, and looking at different professional groups.
You go first. Thank you, Peter. That's an easy question to answer. It is, I mean, when you think about suicide and you think, historically, has always basically been part of the history of humankind. It's something that, as far as we know, in terms of record, has been part. We were talking yesterday about Seneca. We had another talk yesterday about a philosopher, but it's been with us basically since we exist, really, and even as form of mass suicide. So, form of suicide also changed shape in the history. So when you think about that, I do wonder, when I read that about the WHO report, I was one of the reviewers, I was saying, wow, that's a nice ambition, and it would be nice to think it's going to disappear, and I had the same reaction of thinking it's really going to disappear. Can we say it's going to be totally out of the humankind history? Something, within humans that somehow can be, part of life in many ways. So I don't know the answer to that, but I want to think as somebody working in prevention of suicide and being committed to preventing suicide since my first honors thesis some time ago, that I think we can do the best we can to try to prevent suicide in as many people as we can. And as Jason was mentioning before, I think in particular there are at least a part of suicide as linked to issues like can be unemployment. I work on domestic violence and violence against women, and that's my kind of child neglect, and that's my kind of particular kind of take on prevention of suicide. So working on these kind of other issues, which then are related to suicide, and try to reduce and limit as many suicides as possible, because if not all of them, many of them are preventable, and many that can be avoided. So that's, I think, is the best we can really do. And that's my take on it. And Ricardo and Jason.
I don't have anything to add. I think that's exactly right.
Okay. Thank you for the question. And I will think about
There's another question there, Jamila, on that. I don't know who was first. But.
Mary.
Hi, thank you for great talks. My question is for you, Jason. You touched on the Mental Health Act or Mental Care Act. My question was more about the clinicians, in your experience, exercising it as a means of detaining people on the basis of a suspicion of mental illness, or purely as a preventative strategy for reducing suicide. Are the clinicians detaining because they think there's something mentally ill that needs treatment, or are they doing it as a simple preventative means? Are they aware of the sort of difference, essentially, that in some cases it might be appropriate to say, we can't treat you, but we are keeping you here until we feel you're safe to leave?
Yeah, that's a very good question. I think that the use of the Mental Health Care Act, certainly in this setting and our observation over those 8-month periods, was that it's in some ways protects clinicians, so they're interested in reducing immediate risk if they believe someone is going to complete suicide like within the next 24 hours or 48 hours. Sometimes they use it in order to gain more information. So there's insufficient information, they need collateral information, and so it's about buying of time for that. But I think also, unfortunately, the reality is that it's sometimes the decision to execute, to make use of the Mental Health Care Act to involuntarily admit somebody is also dictated by whether their beds are not available. So it's a very, very difficult decision. And in fact, we're going to follow this up with another study that looks much more carefully at clinicians' notes to try and understand the circumstances under which clinicians evoke the Mental Health Care Act in order to involuntarily admit somebody and how they use that. But I think that the way they see it is about reducing immediate risk. They don't believe that involuntary admission is going to be therapeutic per se. And that's certainly what the patients are saying, that involuntary admission is not therapeutic.
I think we have time for two more
Lots of
questions.
questions. Do we have time for
Probably two more.
2 more? Okay. One here, Antonio, and there's another one there.
Yes, I just wanted to focus a little bit on, partly I guess on gatekeeping in a sense, but to what extent do you think in both in low resource contexts it's possible to change the focus a little and actually focus more on the prevention and early intervention for depression, where you see depression as a key trigger or a key risk factor for the risk of self-harm and suicidal events. And to what extent can the gatekeeping and the sort of primary community care interventions have some sort of focus on depression to try and deal with that, or is that unrealistic in the resource settings you're working in?
Thank you. Well, when we do training about suicide, we usually kind of mention some of the mental illness that can be a risk factor for suicide. But I must say, the kind of guidelines we have done don't really have a much of a biomedical kind of approach. It's not much looking about what might be some of the risk factors, because depression is definitely one of them. The reality is that most people who are depressed don't kill themselves. And that's something I think is very important. So we're kind of focusing more kind of on the behaviors and or lack of behaviors, warning signs, and some of the way of thinking. The kind of way of thinking, we know some people who are suicidal, maybe because of their life circumstances and very practical life difficulties that maybe they might result in a depressed mood, or other anxiety or other mental health issues. But these actually are the kind of the issues really to focus on for the person to kind of try to be well. And sometimes it can be the way of starting thinking, in a kind of funnel way, like when you guys basically can't see any way out. So I guess the way in this kind of training that we work on is more about thinking, okay, how can we help the person to try to kind of see that maybe there is some other way out. Suicide is not the only option, because that's a way of thinking that very often brings people to suicide. They're thinking there is really no other option. And for some people, realistically, in some situation, like women I work with, or been working with, who are victims of violence, where really, realistically, they can't see any other solution, because basically, that if they leave the family, they leave the husband who's abusing them, they might as well be dead, because they can't go anywhere. So there is the kind of issues that we're focusing more on this. So independently from why you are there, why suicide seems to you to be your only options, how can we work with that as member of the public, with the limit we can do as a friend, as a family member. But we definitely mention also about the depression as possibly, and in some cases, the main risk factor for suicide. Thank you. And there was another question?
Yeah, there's one final
Yeah, Antonio?
one. Can we do one final one?
It was identical to...
Ah, there we go. 2 for 1.
So maybe can we take one from Professor Pariante? Yeah? Could you bring the microphone? Oh, yeah.
Erminia, this prevention program, the gatekeeper and so on, I mean, obviously you're spending a lot of energy in the developing countries. Is it something similar in high-income countries?
Yeah. So there are different kind of training about different things, as you all imagine. So they say the ones that have been somehow evaluated, where there has been some kind of research going on, where there is some kind of qualification or validity. There is one called ASSIST, which is very widespread in Australia. I believe it's also offered in UK, in Asia, in US. There is a QPR, which is developed in Canada, but also is one of the main one actually in USA and in Canada. So there are training packages for high-income countries, usually developed within high-income countries. And part of the reason why we developed some kind of other guidelines for gatekeepers training, which actually were based in Asian countries and migrants and refugee communities, somehow to complement these other kind of training guidelines and instruments, which were mainly only, I should say, developed for and in high-income countries. Because also, like the way when you do gatekeepers training, normally the kind of what you're really training people at is recognizing signs for suicide and then try to basically connect the person to professional help. And that on its own can be an issue, because in many contexts there is not really help. And Vikram Patel is in this ground where we are now, has been writing about where there is no psychiatrist, which is a situation in the majority of all low middle income countries. I was here actually in this theater 2 years ago showing a documentary, visual anthropology, about human rights violations in Indonesia. And one of the person I filmed was the only psychiatrist in Indonesia for an area of 2 million people. Now, if you are the only psychiatrist where there are 2 million people, and you go there, you do your training about preventing suicide, and you're telling people, okay, so if you're thinking about killing yourself, go to see the psychiatrist. And there is one man who works very hard, but it's not going to do much. So it's about also realizing the limit about what we are training people, what we are telling people. So sometimes I wonder about in thinking about the solution to suicide is mental health professionals. It is not the only solution. Sometimes it's not the most relevant when people don't see themselves having a mental health problems, or where the real issue resides in other area, part of their life. And maybe the reason that help is not possible in the places where I was in Indonesia, sometimes even to reach the village was like 8 hours walking. I went somewhere where it took me 10 hours, my motorbike, go to find somebody who was seriously mentally ill. When somebody is unwell, they can't just go and access professional help. So part of the training is also about thinking what actually we can offer in low-resource country. And think about, health officers, community, very, very basically trained people who go in the community. They have a very basic understanding about mental health, but they can do a lot. And they actually can volunteer, perhaps go in the community and be able to provide help. So the kind of strategies in low-income countries can actually be very different from what we can offer in high-income countries. So, but yeah.
I think we're going to have
To stop.
close it here.
Thank you.
Just to say that I know some people here who've done research on suicide in several other countries. I can recognize you. So you can approach any of our speakers and talk at the end. I think, Chamaila, you were going to make an announcement.
Yeah, I'll put it up as well, but we're going to be heading to a pub near or down the street,
Nice.
and I'll put the address around the and see if you have any other questions for the speakers or if
That's I like this announcement. And thank you so much for having us here, Shamala and Valentina, Ricardo. Thank you so much for coming.
It's just the opposite. Thanks so much for the two of you to have come and share your experiences with us, and to all of you who have taken the time to come with such an important day for all of us.
Thank you.
Thank you.